Now it's Vlado and Marina that will show us their experience from Zagreb.
It's not just Vlada and Marina, it's me for the beginning. Okay. So I would like to wish you all once again a very good day in front of Department of Neurology, Sestre Milosrdnice University Hospital. It's very nice to be here, especially in this kind of joint venture together with neurointerventionalist. Why is it very important, and how tight we should all be in everyday life? We should be together 24/7, and the one situation from our life shows that that's how it's going in our hospital. I'm fortunate to have a husband whose name is the same as my interventionalist. The name is Vlado, so I'm not making that much mistakes in that field, but is completely different situation with my interventionalist Vlado. He doesn't have a wife in the same name as I am, so not very rarely in the everyday life is happening to me that he's calling me with the same name after his wife. So that's how tight we are, and that's how tight we should be. Let me show you our patient from everyday, our stroke patient from everyday life. Early this morning, we started the working session with talking about also about the discussion, discussing about the patients which were not completely inside of guidelines of treating these patients. So this is the situation we had in our life. So let me introduce our 45-old patient who was a car mechanic, previously with ranking scale of 0, and considering regular stroke risk factor, nothing except smoking a pack of cigarette per day. His problems started at approximately 9 p.m. that night, with not feeling very well, and with the feeling that something's wrong going on with him, but he didn't recognize his symptom and didn't seek for help for many hours afterwards. Approximately at 2 a.m. In that period, he felt very strong weakness of the left extremities. And yet at 9 a.m. his girlfriend managed to call him on a telephone, and he managed to answer that phone call, and his speech was slurred, and she realized that something bad was going on, and she called the emergency medicine, and approximately an hour later he was in our neurological emergency department with a headache, nausea, vomiting, and a pretty high NIH stroke scale of 10. If you see all the neurological deficits that he had, then you can realize that it wasn't just 10, it was much higher at that time, unfortunately, and that's what usually happens worldwide in the emergency settings, that we are basically decreasing NIH because of fast calculations. So what we did immediately was, of course, emergency imaging of the brain. So Vlado, please.
So I will continue as we share all these patients, and we see that we have hyperdense media sign, and we see the markers for the aspect score, which are then calculated, and it was a very, very bad aspect score which he got. And then we proceed to do a CTP to assess what is the salvageable part, if there is any, and in which direction we are going to go with that patient. And we saw that he had elevated mean transit time and time to peak, and there is a little bit of green soluble area on the cortical part of the perfused territory. So in our discussion then and what to do, he's a young patient, and as you know, in everyday life, they start to calling you outside the hospital, this is my guy, do something with him, do something, can you do it? And then you feel obligation also as you have as a doctor and a friend to try to do something. So we then, this is the CT angio. So you see that collaterals are not so good, and you want to help a patient. So we decided to do mechanical thrombectomy even in that setting, which is over 10 hours, and we did a combined approach here with using of a stent retrieval and aspiration catheter, and we achieved a score of TK2B, and we saw that there is a dissection in the upper cervical part, which we tend to believe was the cause of the occlusion of the artery. That was done in our own angio room because there was an issue with the new room. So we had only monoplane, and then after that we have a control CT which we did, and to assess the situation after, and which is related to the Stefanos lecture few minutes ago. What do we see here? And we see a mix of everything, and we see that there is some contrast here, but also we saw blood, and we were not happy with that, and he was deteriorating in clinical state. And so we see the progression in the following day, and we see the removing on the contrast, but there is still some hyperdensity there. And so we are following the patient and the clinical situation, what is going to happen after this. And Marina, you can continue.
Thank you, Vlado. So that's the third day in our hospital, severe deterioration of the state of consciousness of our patient, and what we did again, of course, immediate control CAT scan that showed
that showed better demarcation and edema. So as you know how the ischemia is going, the compression of the structures and the contralateral shift. And so our hope to do something with thrombectomy was not in our favor, and we see that there is a demand now something to do which is in the field of neurosurgery, because his progression will be very poorly if we don't do something. And so we then contacted Marina.
We contacted our neurosurgeons, and we pushed them and pushed them and pushed them really hard, as we do in everyday life. And finally, we have managed to have them have the compressive craniectomy in our patients. So this is 4 days after the compressive craniectomy. Our patient is, of course, on mechanical ventilation, analogous sedated, but this is the 12th day after the compressive craniectomy, showing a very good improvement of his.
Yeah, so we see that there is some left parenchyma which we managed to save, and we have a better demarcation of former ischemia, and also that craniectomy did a job, and we saw that now we have a shift through the entry to the opening of the craniotomy to the outside the skull.
So during the whole hospitalization period, we did all the diagnostic workup possible for our patient, as well as a control CT angio showing a still dissection flap of the right ICA without limitation of blood flow. During the whole time, his blood pressure was good, his blood sugar was good. We treated him with all possible best medical treatment, with neurorehabilitation, accompanied, of course, with the speech-language therapist. He's all together, he was on mechanical ventilation for more than 10 days, and all the diagnostic workup that we didn't find the exact etiology of this ischemic stroke. So our patient was dismissed from our hospital on the 27th day with an NIH score of 10, but altogether when you see that he had a moderate dysarthria, facial nerve paresis, left arm plegia, moderate left leg paresis, and hemihypesthesia of the left side, and when you have in your mind his brain imaging, then we were very happy with this result, although the ranking scale was at that time of 4. So we sent him to the neurorehabilitation, and fortunately we talked about that this morning. Also, he was the one of our patients that could have a really good, basically the best rehabilitation possible. So altogether, a neurologist, interventionalist, and neurorehabilitation, basically you will see result in a couple of minutes. On the first neurological control exam, his NIH decreased to 5 and ranking to 3. Again, control CTA found the dissection flap without limitation of the flow, and altogether he did the cranioplasty and sorry. Can it go back? No. Which button? Sorry. Thank you. So just a couple of minutes to see where do we stand here in the matter of theory for this kind of patients with a very low aspect score and also extended time window. The main paradigm in everyday life and treating patients is a lower aspect is a worse outcome. As far as we know by now, all the randomized controlled trials were basically excluding patients with low aspects, except of just a couple of them, and these are the results of the studies published in the past, let's say, 2 years. In Aurora trial published in 2022, there was a small proportion of patients with a low aspect, up to 5, but the results didn't, basically, the benefit remained unclear. Then there is another VIVAS-CAT study where they compare patients up to 8 hours from last seeing well, and the CT aspect more than 6 and MRI aspect more than 5. And basically what they found out that in patients with aspect score more than 6 or 7, the good outcome happened in 20% of patients, but if perfusion was achieved in more than 8 hours from last seeing well. Rescue Japan Limit study, I'll talk about that study in more detail soon. Then another study published in 2021 with a large vessel occlusion and aspect from 2 to 5. Performed in 28 centers in USA, Europe, and Asia in a pretty large amount of patients for this group of patients in general, more than 2,300. And what they did, they compared the patients with a good outcome as measured as a ranking scale from 0 to 2 in the early time window, less than 6 hours, to extended time window from 6 to 28. And they found out that in up to 20% of patients, they had a good outcome, TC more than 2B. And in group of patients of aspect 2 to 5, much more often than in the group of patients with a low aspect, but which had a TC less than 2B. So what would it mean? That in 1 of 5 patients, basically, with a pretty low aspect, from 2 to 5, the outcome was pretty good. So it would be like 5 times more favorable outcome for these patients with a good, successful recanalization. When we talk about the difference in the time window, early compared to extended time window, there was no difference in considering that time window, and what they concluded that in the group of patients with a low aspect and perform mechanical thrombectomy with a successful recanalization, the outcome can be pretty good pretty often. Another study that compared a group of patients that fulfill criteria of Doan and diffuse 3 and the one that did not, they found out that basically what we already mentioned this morning, that the greatest impact on the outcome has basically in the group of patients of large baseline ischemia, vasal status, and that is the most important thing when selecting patients for EVT, especially in the extended time window. And the Rescue Japan Limit trial that I mentioned before, they measured the good outcome not as a ranking scale from 0 to 2, but ranking from 0 to 3. And also patients with the low aspect score, comparing aspect of 3 or less versus 4 to 5. And they found out that in patients with aspect from 4 to 5, they can have a safe and effective outcome, while in their study, the patients with aspect less than 3, they did not reach the good outcome, and they had increased number of symptomatic intracerebral hemorrhages in the after 48 hours. So we got a couple of other answers from the previous studies published less than a year ago. The first question was, is thrombectomy associated with better functional outcome for patients with ischemic stroke in the extended time window with extensive signs of infarction? And from results from German Stroke Registry, they showed that in the patients with aspect from 3 to 5, they could have a good or improved outcome if the time window is in approximately 17 hours. While another question, very interesting question that we also talk about this morning, was whether patients with large vessel occlusion ischemic stroke may benefit from referral to a distant tertiary center for thrombectomy. And their results show, the retrospective analysis, that in older patients, diabetic patients with a high NIH stroke scale and low aspect, it may be better not to transfer them because they may not benefit from transfer to hub center many hours away from MT. Results from Mr. Clean late in Netherlands, published a couple of months ago, also comparing good outcome in thrombectomy patients 3 versus 4. The all-cause mortality didn't differ, but the ranking scale was lower, 3 versus 4, in the group of a thrombectomy combined with best medical treatment, although in that group they had increased number of symptomatic intracerebral hemorrhage. And then at the end, results from rather small group of patients, but still important one, 27 of them, with ultra-extended window. The average time window was more than 35 hours. Their results showed something that we should all think about. It was no signal of benefit, but in the same time of harm with the thrombectomy patients in the ultra-extended time window. So what we could conclude out of knowledge with real-life patients and also of the studies, that the feasibility of thrombectomy in the extended time window should be done in carefully selected patients. And basically, as we know by now, selection of patients for EVT in the late window could be primarily based on the presence of collateral flow. So that's what we do in the everyday life, and we base our decisions on that kind of knowledge. So this is our patient that we show you together a couple of minutes ago. So if we ask ourselves, is it worth? We think it is. So what we did, deciding how to treat these patients, we basically jumped out of the window in all the aspects. That was a patient with the extended time window and a very low aspect score. So we jumped out of the window with a much success. I guess you would all agree in that. And what do we need in our future everyday life deciding for our patients? Well, basically, we have all sorts of time of the windows, as you can see. So we would need the results of the future trials with involving patients with large ischemic score, with conventional extended, but also ultra-extended time window. And basically, we jumped out of the window, but we would do it again. That wasn't our first time and probably not the last time, but we always jump with a parachute and we always jump with the help of our superheroes. So we are deciding individually for every single patient and with all the knowledge we have. And in the situations when our window closes, we try to open the door because we all know that we have something that is called late recovery. And we are aware of that, even though in some situations with the patients, when you think that the outcome won't be good, still it happens. We have something that is called stunned brain. We still are not doing so well with anti-edematous therapy, as you probably know, and we still don't have much good weapons with the neuroprotection and hoping to have those in the near future. And out of our window, this is a part of our group, just a small part of our group, and this thing in MUG over there is our new neurological department that is growing on. So we hope that we'll see some of you as our colleagues sometimes in the future. Thank you.
I mean, for me, it's not a question for the extended time window. It's a question of how brain looks, what's the condition of the brain. And you showed here the very low aspect that can go well. And the major question for me is it thrombectomy? Is any recanalization by thrombectomy, not by IV thrombolysis? Recanalization by thrombectomy can be harmful or not, even this so low aspect. We don't talk about, futile thrombectomy, but can it be harmful? Can we say it's not harmful? And we can do it and try to make it good for such patient.
Yeah, that is my main point. Did we do anything with thrombectomy, or we did everything by craniectomy? Do we need to do thrombectomy in those cases?
But
to do craniectomies?
Are you surgeons happy?
No, they are not.
They hate us. But I think that the result in this case was a joint thrombectomy and craniectomy, because we all know that if you do the thrombectomy, then the edema will be less prone. So probably it is something combined.
I have a comment on the craniectomy. Is there a neurosurgeon in the room? Okay. What do you think of that craniectomy? Because it was small, exactly. So first of all, it was small. No, first of all, it was late. So it should have been, as soon as you see the first day that all that big infarct, especially in a young person, you go directly to craniectomy and you do it large, very large, because otherwise, as we have seen, the brain comes out, it's like a mushroom through the window of the craniectomy, and then it compresses the veins. And so you have a worse outcome on the brain if you do it small rather than nothing. So it larger and sooner, and maybe you would have had a better outcome. So the complication in your case is not the thrombectomy, but it's the craniectomy, to my eyes. It could have been much better with a larger and sooner and earlier craniectomy. But certainly it's very important to go to craniectomy in all these cases, especially, of course, in young people. So you should go and talk to the neurosurgeons and convince them.
Thank you very much for this comment. Then you can have a clue what we are dealing with in everyday life, because it took us 3 days to get that craniectomy, and we really pushed them.
And thrombectomy helped that he receives the craniectomy, because if they request craniectomy without the thrombectomy, they will never do it. So they said, oh, you have a bleeding after thrombectomy, we are going to save you. So it's we did something by thrombectomy to force them to do craniectomy.
But that's how it goes.
I perfectly understand you, because I have exactly the same situation, and every time you have to seek the surgeons and for having the craniectomy done in a relatively short time. And the other, even because in a young guy, if you wait for the clinical deterioration, then the time between the clinical deterioration and the real decompression, meaning the time the surgeon is taking the bone out, it's hours, at least hours, if you're lucky.
We are encountering this from the start, and luckily it's way from good, and we are having difficulties to persuade them to do craniectomies. And when we see some early signs, as you say, and we try to force them, do it now. No. We are going to wait, do a CT in 6 hours, do a CT in 16 hours, do it in the morning. And so we lose the patients. In that time, they're declining the surgery. So we are forcing them. They are doing more craniectomies than before, because in the past they did not do any at all. So 1 is better than 0. But what can you do? It's their territory. It's a long way.
Yeah. Most of our neurosurgeons are, of course, men. All of our neurointerventionalists are men. And not all, but 80% of our neurological intensive neurologist intensive care unit are women. So yes, I think
I don't know how that is related, but
me neither.
This is a foundation for a study to see.
I'm asking
when
for a friend.
Interventionalists ask,
not for me.
How much reply do you get, and then you ask. So yes. But this is a big neurosurgical fan club here, so we're happy to be. Everything is the same. I'm sorry to hear that it's the same in Italy also, because I thought it's regional thing that neurosurgeons are like this. But hopefully we have colleagues that do that. We had also, you always have to have local conditions, and this is unfortunately our local condition. We had one neurosurgeon that wanted to do that, and he left the hospital. So now we are back to the stage 1.
Great.
Yeah, yes.
Okay.
Thank you.
Thank you.